All right, welcome everybody to our pituitary review. We're going to stick to pretty basic principles here. The idea being that it gets overwhelming pretty quickly, and I'd rather you left with three good points that you could keep in mind than have a thorough discussion in hopefully less than 30 minutes. Note when we review the ABA keywords how much of them focus on ADH, so that's going to include diabetes insipidus and syndrome of inappropriate ADH. We'll save those for the end. But let's just get started. Two parts to the pituitary, the anterior and the posterior. I'll bring this up a few times throughout the talk. The anterior is the majority of the hormones that we think of coming from the hypothalamus stalk. TSH, ACTH, remember ACTH correlates with the cortisol level. The other ones, except for growth hormone, we don't tend to direct too much with perioperatively. Keep in mind that prolactin is probably the most common, but that won't show up on an anesthesia exam. The posterior, for our purposes, is antidiuretic hormone, okay? As I said, the majority of these questions, and certainly what we deal with in the neurocritical care unit, relate to the posterior pituitary. A picture to help you with retention. The oxytocin we don't care too much about outside of or in the neuro world, but vasopressin comes up a lot. Let's get to our first syndrome. Talk with acromegaly here. Start with a question. Which of the following is most appropriate lab value for screening for acromegaly? I'll get back to that in just a little bit, okay? The acromegaly patient we see not infrequently because of the type of surgeries we do here. Just a quick review. This has come up in our difficult airway lecture from maybe about a year ago. If you want to look at it in more detail, there's overgrowth of essentially everything is the way to keep in mind. It has particular anesthetic complications that you have to know ahead of time. The classic one is the difficult intubation history here. Not as many as I would anecdotally say, meaning that in my experience, they tend to have changes to the airway that are associated with difficult intubation. We live in a world of videoscopes and ready bronchoscopes, so sometimes what we would otherwise call difficult intubation we don't appreciate. One of the things that I've emphasized to you before is that even if everything on the external exam is reassuring, my recommendation is to bring a glide scope or a fiber optic scope into the room anyway, because what I found is the patients are difficult to intubate. It doesn't mean that a video scope isn't enough to compensate for that difficulty, but what I see is that the mobility of the tissues is changed. So the tongue is big, the soft tissue around the oropharynx is big, the epiglottis is big, but all that I can deal with. And then when I go to lift the epiglottis, it just doesn't move very much. And the last two patients that I've done that have acromegaly, both, although I was pretty sure it would be okay from the external airway exam, found that the tissue mobility was what caused the difficulty once we were in the operating room. The classic test question relates to ulnar artery flow. This doesn't mean it's kind of it gets kind of tricky sometimes because the anatomy change is related to ulnar artery insufficiency. And the question is, do you place a radial art line? Well, on one hand, you'd say, well, yeah, radial art line's fine because it's the ulnar artery that's compromised. But consider you still have to perfuse the hand. So the Allen's test becomes critically important. And I know in my life, where we do a lot of those procedures, I've at least one time not put an radial artery line in at all, just based on the poor collateralization from the ulnar side. So remember, it's not necessarily going to be your best option. There's cardiomyopathy, EKG changes, difficult mass ventilation. All of these things are to be expected, okay? Getting back to the question here, it's kind of a trivia as much as anything, but the screening lab is actually IGF-1, not growth hormone. This level is not a standard level, meaning that 10, for example, is not normal for everybody. Age and gender match controls. So when our laboratory reports this, they'll break it up by age and gender so you get an idea what the level means. The reason the growth hormone isn't used is it's diurnal. As you probably remember, it cycles throughout the day-night cycle, and it makes it harder to interpret. A couple of clinical caveats here to keep in mind. When we do these procedures, it's very common to see a vigorous diuresis after the case. If you consider the growth hormone, all the physiologic features that you see looking at this guy here. Some of that also includes being hypertensive with volume status being up, and when you take care of the tumor, the patient just normalizes. In other words, it does not mean they have diabetes insipidus. So if this becomes a clinical question, it doesn't mean they don't have it, of course, but consider that this is kind of par for the course. Specifically for us, with how much glucocorticoid administration we give perioperatively in the neuro operating room, but also in general for post-op nausea, vomiting prophylaxis, try to avoid glucocorticoid administration. For the endocrine consult after the case, they will be following cortisol levels serially for 2 or 3 days, and us giving, say, 8 milligrams of Decadron will affect those levels and make the assessment of function and success more difficult to interpret. The next syndrome we'll talk about is Cushing's disease. I can't stand the term. It makes it hard for me to remember, but Cushing's and cortisol have enough letters in them to help me keep it straight. The patient here is all the classic things we all knew from medical school or pre-medical school. Hypercortisolemia does all of the things listed here. Those are usually pretty easy to keep in mind. The one I struggle with is hypernatremia, hypokalemia. Here's a test question I wrote kind of recently related to this. Which of the following is most associated with Cushing's disease? I'll let you think through that. I won't tell you the answer here. But one of the things that I use to keep it in mind and not get confused is what I have marked here. When I consider adrenal insufficiency, which if anything we're probably more comfortable with that idea because a lot of our patients are on steroids, and in the ICU in a septic patient it is something that comes up routinely. That tells me a classic sodium and potassium ratio or relative levels. And essentially, if you view this, which you're probably more familiar with, this being adrenal insufficiency, and compared to excess cortisol, you could probably, at least in simplified terms, consider it to be the opposite. So if you in your head listening right now know what happens to your sodium and your potassium in adrenal insufficiency, if you consider the opposite looking at these choices here, you should be able to come to the answer. I won't give you the answer here, but if you look at the associated questions for self-assessment, there's enough of a answer in the or description in the answer to get you the rest of the way there. I mentioned earlier anterior and posterior pituitary. From our perspectives, the posterior pituitary ADH is the main thing we are concerned with. This is stolen from some of my notes, an informal lecture that I give. Diabetes insipidus, as you would guess, is insufficient antidiuretic hormone that causes increased urine output. This list, I want you to, not with me here, really go over and think about a little bit. There's a lot of words written here. It doesn't add up to very much, and it makes it pretty easy diagnosis. Essentially, when the nurses call and talk about increased urine output, the first thing I ask is how much over the last couple hours. If they're not somewhere near or above 250 cc's per hour, I tell them, okay, just keep up with the urine. Let's not do anything else at this point. As soon as we get that pre-screen of increasing urine output to this degree, we'll take the next diagnostic step to assess the specific gravity. Between, and this is very simple, between the dilute urine of diabetes insipidus and the concentration in the serum, we can come up with the diagnosis pretty readily. All right, so 10-10 is the classic cutoff. 1.010 on the specific gravity. This is a bedside exam. It will take any time at all to get. I don't personally find dilute urine with osmolality very useful. This I get right away. This doesn't come right away. This is what we're used to talking about. This we're not. I include it here because it's in all of your textbooks. For DI, if you could imagine all that free water being urinated off, serum sodium is going to be normal or high. In most neurocritical care patients, we won't be able to do a water deprivation test, but on the floor, on general medicine patients, this is what happens. You give the patient less water, you see the urine output decrease and the urine osm increase to get a diagnosis. This isn't really appropriate in our patients, especially consider we're at risk for running the patient into hypovolemia. So a water deprivation test is the last thing they need anyway, let alone the neurocritical care principles. What do? Well, I told you diabetes insipidus is a lack of ADH, so we give them ADH and we hydrate them back up to normal. As you hydrate them, you get your sodium normalized again if they got hypovolemic enough to get hypernatremic. And I don't bolus with the half normal saline. Essentially, I'll give them, say, a LR or a saline liter bolus to get them caught back up. Then we'll switch to half normal saline to maintain euvolemia until everything normalizes out. Essentially, what you'll see is this 1 milligram desmopressin shot is enough to decrease your urine output and help everything start to normalize. After that, it's endocrine consult and more long-term management. There are different phases of DI. We don't need to get into that. All you need to do is be able to recognize it and get a few questions right on it. Vasopressin, or DDAVP, is the treatment after you get the decent hydration. Since we're monitoring it so closely in the unit, it's not very often that they end up getting very hypernatremic and hypovolemic, since we can monitor every hour on the urine output. Diabetes insipidus concern is the reason that Dr. Fraser sends his transphenyls to the ICU for post-op monitoring for 1 or 2 days until we get that settled in, and then he trusts that we can keep track of it on the floor. The opposite end of the spectrum of ADH is the inappropriate ADH. This is too much ADH, and as you could imagine, patients are hypervolemic, not hypovolemic. So what do you see? Think of this, although it's not entirely true, as diluting out your variables. So your sodium becomes low, your serum osm becomes low as opposed to high on the diabetes insipidus. Your urine is more concentrated, so your urine sodium is above 18. I include this even though I don't really use urine sodiums, as those of you who rotated through neurocritical care know, because it's a valid test question and it happens to be the cutoff for wedge and ARDS, so it's easy to remember. Sometimes we'll use loop diuretics to poison the kidneys and cause more diuresis. The classic questions for the anesthesia test is democlocycline. Its side effect is nephrogenic DI, so it compensates for the ADH excess. These days, what we're using is conivaptan in the unit. This is the ICU drug. This is the long-term outpatient kind of drug, and these are vasopressin receptor antagonists. The plasma B endocretin isn't as useful in a critical care setting, but it is in both ours and neurosurgery textbooks, so I include it here. So ADH, volume up, concentrated urine, confirmed with a dilute serum osm, and democlocycline or conivaptan is what we use in our setting, okay? What risk factors are there? I mentioned at the beginning that there's so many test questions on ADH. I don't really think it's worth even mentioning, because if you look at the list, if you remember from medical school, the list is anything that stresses the body and about every drug. So all of our perioperative patients are at risk for holding on to excess fluid from excess ADH. There's no reason to ask more specifically than that, in my opinion. If you compare the two, I won't walk through this with you now. If you have any questions, just email me, but I hope after that very brief discussion, it's very obvious that these are opposite, these are opposite, these are opposite, these are opposites, and it just helps clarify it in your head. That's why I include it here. Last one we want to talk about is pituitary apoplexy. So essentially, Dr. Fraser will post a transphenyl on Saturday morning as an A, and then I'll get called saying, why are we doing a transphenyl as an A emergency on a Saturday morning? And most likely, it's this patient. This is bleeding into the pituitary. Usually there's a associated tumor, the adenomas that we see for every scheduled pituitary resection. The presentation can be impressive, and think about this for a minute. If you shut off everything from the pituitary, so the hormones that we listed at the top, if we just took those away, what would the patient look like? Okay, so in particular, they don't have ADH, thyroid hormone, or cortisol. If I think about the most severe patient that I've seen, which happened to be a Saturday morning when I got called in to do that case, it was absolutely remarkable. So what did it look like if you started to guess? The patient's mental status was very slow. It looked like he had excessive alcohol and was sleep deprived. His words were slurred. He spoke very slowly and very simply. I thought that was interesting. He was bradycardic, hyponatremic, hypovolemic, hypotensive, and volume depleted. So you can imagine all of those variables, and you probably could think of a few more abnormalities that would occur, really would affect our anesthetic management. Clinical tip for those patients, even if you don't have all the details, like all of the hormone levels back, is give hydrocortisone 50 or 100. We gave 100, and that's what we kind of do here. IV, and you can actually see a pretty quick turnaround of heart rate, blood pressure, mental status just from that bump there. Keep in mind, although the patient ended up needing thyroid hormone, there's a lot of overlap on these cases as with your CODA patients, your care of your peri-donation patients, because all those axes are gone. If you give the thyroid hormone first, it speeds up metabolism. It chews through what little hydrocortisone and cortisol specifically you have left and leads to acute adrenal insufficiency, which is one of the main reasons that we want to get involved with the care right away. So essentially, this patient gets volume resuscitated, and they get hydrocortisone, and then the rest of the hormones we can work through. Here's a guide from a UK policy just to include on here, and it's to emphasize that they need to be supported hemodynamically, and if without all the details, empirically, give some hydrocortisone, and then go ahead and proceed with the surgery while we work through, with the help of an endocrinologist, the rest of the deficiencies. There's more self-assessment questions on the wiki. Thank you for listening. You can email me at any time with questions, and we have a related, more of an emergency focus PBL on Thursday if you need a little more exposure.